we will discuss the development of respiratory system. Now, lungs or respiratory system, they are developing from lung bud arising from the foregut. Now, it is endodermal region which is going to form the lining epithelium. Then subplanchnic mesoderm, it is going to form the connective tissue, cartilage and muscles. Now, what are the sequences of events which are occurring in this development is, it starts developing fourth week. At fourth week, respiratory diverticulum, an outgrowth from the ventral aspect of cranial part of foregut, it arises. Then a laryngotracheal groove, which is caudal to the hypobronchial eminence in the floor of pharynx, it appears. Now this groove deepens to form the laryngotracheal tube, you can see here. Then bifurcation of the tube is happening into right and left lung buds. The distal part of the diverticulum separated from the esophagus by the tracheoesophageal groove. So this is how the groove it appears. In this TS section you can see. So a groove, tracheoesophageal groove, is appearing in this portion. Now cranial part continues to communicate with the pharynx. This communication is called as laryngeal inlet. Now larynx is developing from the cranial most part of the respiratory diverticulum. So laryngotracheal source is the basically for the development of larynx. Then communication between diverticulum and the pharynx persists as the inlet of the larynx. Now differential growth is happening 4 to 6 arches mesenchyme. So that differential growth is happening in those arches. Now the lining epithelium is derived from the endoderm of the laryngotracheal diverticulum. Vestibular and vocal folds for the larynx, they are arising from the endodermal folds. They are arising from the laryngotracheal tube. Now the cartilages of larynx, that is 4th and 6th arches except epiglottis, which is derived from hypobronchial eminence. So this is the source for the cartilages of the larynx. Then muscles, they are derived from the 6th arch except cricothyroid muscle that develop from the 4th arch. Now nerve supply is derived from superior laryngeal nerve because that is the nerve of 4th arch, and recurrent laryngeal nerve, that is the nerve of 6th arch. So this is the development of the larynx, which is going to give rise to the lining epithelium, then vestibular and vocal folds, then cartilages of larynx, muscles and nerve supply. So this slide is including the whole development of the larynx, how they are developing. Now you can see this diagram. Now keeping in mind this development, what are the anomalies which can occur in larynx is, laryngeal atresia or stenosis occurs due to the failure of recanalization of the larynx, most commonly seen at the level of vocal folds. Then laryngeal web is web-like tissue is present in the laryngeal lumen, usually at the level of vocal folds. So web-like tissue is derived from the endodermal cells that fails to break during recanalization. Then coming to the development of the trachea, the part of the respiratory diverticulum which was arising from the foregut lies between the point of its bifurcation and larynx, because initial segment is going to form the larynx. Now rest of the part that is up to the bifurcation, so that part is going to develop into trachea. Now two divisions of respiratory diverticulum form the right and left principal bronchi, you can see here. Now left division comes to lie more transversely than the right one, and it soon shows the two subdivisions that represent the lobar bronchi of the left lung. So you can see this left bronchus, which is more in line with the basically with the trachea, in that plane of the trachea. So then right division divides into three lobar bronchi, you can see. The further subdivision is happening into those tubes or into that bifurcation which is happening after the tracheal end, because initial segment is going to form the trachea and bifurcated end is going to form the principal bronchi. Now tracheoesophageal fistula, abnormal communication between trachea and esophagus, it happens. Failure of the tracheoesophageal septum, so complete fusion of this septum is not occurring, leading into this the formation of this fistula. So occurs approximately 1 in 3000 births, common in males. In about 30% of cases, tracheoesophageal fistula may be associated with other anomalies. So tracheoesophageal fistula may be a component of vectral. What is that? That is vertebral anomalies, anal atresia, then cardiac defects. Then tracheoesophageal fistula is one component of this vectral component. Then esophageal atresia, then renal anomalies and limb defects. So this is basically a condition which is involving one segment, that is tracheoesophageal fistula. Now, this is the percentage how it is visible. That is, fistula in lower part is seen in 90% cases. So, without fistula, you can see here that is proximal and distal, and they are not fused with each other, and even they are not communicating with this tracheal end. Then fistula, but no trachea, it is seen in 4% cases. So then is fistula in upper part is seen in 1% cases, and fistula, that is both the proximal and distal segments, they open independently. So in the trachea, so that is seen in 1% cases. Now coming to the lung development. Lung development, that is, we know that respiratory diverticulum is there, lower end is bifurcated, then larynx is developing from the uppermost part of the diverticulum, trachea is developing from that segment which is going to form the larynx up to the bifurcation, that region is going to form the trachea. Then subdivision happens, which are of the lung bud is there, which is going to form the bronchi and lung parenchyma. So that we will discuss in next slide. Now, development of the lung, if we consider that the free caudal end of diverticulum becomes bifid, that is clear. Lung bed each subdivides. Now, cranial to the bifurcation, larynx and trachea is formed, that is clear to you. Then, lung bud is going to form the bronchi and lung parenchyma. So, this is important. Then, formation of the bronchus. At fifth week of development, lung bud grows laterally into the pericardio-peritoneal canals, which form the pleural cavities. Now, buds enlarge to form the right and left main bronchus. Right forms three secondary bronchi, then left forms the two secondary bronchi. Now, secondary bronchi is further dividing into tertiary or segmental bronchi, creating the bronchopulmonary segments, which are 10 in number on each side. So, by 24 weeks, 17 order of branches are formed, respiratory bronchioles are formed. At birth, additional 7 orders of branches are formed, means further branching is happening. Lung assumes more caudal position, and bifurcation of the trachea at fourth thoracic vertebral level it happens. Now, if we consider the development of the lung, it is happening in four stages. That is pseudoglandular stage, which is from 5th to 17th week of intrauterine life. Then canalicular period is from 17 to 24 weeks. Then terminal sac is from the 24 weeks to birth, and alveolar period is from late fetal life to about 8 years after birth. Now, first stage is the pseudoglandular period. You can see in the diagram, which is taken from your standard textbook. So, it resembles an exocrine gland, hence called a pseudoglandular period. Most of the major elements of the lungs are formed except those involved in gaseous exchange. So, picture is just like endocrine gland. So, it is given pseudoglandular stage. Then canalicular period is increase in the lumina of the bronchi and terminal bronchi because the division is happening. Then increase vascularity of the lung tissue. Then terminal bronchioles give rise to 2 to 3 respiratory bronchioles, and the development of the alveoli it happens. Then respiration possible at the end of this period. Fetus born at the end of this stage can survive. So this is the canalicular stage, which is from 17 to 24 weeks. Now coming to the terminal stage, this is more terminal sacs are formed, epithelium become very thin, then capillaries begin to bulge into the wall of primary alveoli, thinning of the blood air barrier. Terminal sacs or alveoli are lined by two types of cell, that is type 1 and type 2 pneumocytes. So type 1 pneumocytes are also given the name alveolar cells, which are squamous epithelial cells basically. So it is lined by these cells. So terminal alveoli they are formed, and this stage is from 24 weeks to birth. Now, type 2 pneumocytes, they secrete the surfactant that forms a thin film on the walls of the primitive alveoli. So, reduces the surface tension and helps in the alveolar expansion. So, this is the role of type 2 pneumocytes. Now, coming to the terminal sac period in continuation with that what is happening till birth, or you can say at the stage that is 26 to 28 weeks of intrauterine life, sufficient terminal sacs and the surfactants are present to primitive survival of the prematurely born baby. Now 28 weeks age is referred as the age of viability. So up to this the alveoli they are covered by the surfactant. So this is the without surfactant collapse of the alveoli occur, and that condition is given the name atelectasis, or we call it as hyaline membrane disease. So these are the stages again, beginning of fourth week. This is how the stages they are happening. This is just the revision what we have studied. Now up to 8 weeks, this thing is happening. Then 28 days, you can see the planktonic mesoderm, it appears, bronchial tree is there. Then 38 weeks, the more bifurcation or more division, sorry, more division of these the bronchioles it happens. So you can see the lung surface area of the lung tissue is increasing, of the tubular lung tissue is increasing. Now 42 weeks, you can see the segmental bronchi there appear, and at this stage the different lobes they are appearing, and the division of the different bronchi you can see in this diagram. Now hyaline membrane disease, this it resembles the glassy hyaline membrane, hence named hyaline membrane disease, then also called as surfactant deficiency disorder, produced in premature infants due to less surfactant. Alveoli contain fluid with high protein incidence. It affects about 1% of infants, leading cause of death in premature infants. So this is the X-ray picture of the hyaline membrane disease. The signs are tachypnea, that is rapid breathing, tachycardia, that is faster heart rate, and cyanosis, that is bluish discoloration of the skin. So this is the histological picture of appearance of the hyaline membrane, it appears. Then pathological finding, if we see on in the slide, the waxy appearing layers of hyaline membrane lining the collapsed alveoli of the lung, so that is visible. So how we can prevent this disease? To speed up the production of surfactant, that is injectable glucocorticoids are given to the mother in last trimester. So treatment is newborns can be supported with oxygen therapy, and exogenous surfactant can be added. Fourth stage is alveolar period, from the late fetal life to about 8 years. Epithelial lining of the terminal sac becomes extremely thin. Capillaries bulge into the terminal sac. Alveolo-capillary membrane, that is respiratory membrane, is thin enough to permit the gaseous exchange. So 95% alveoli develop after birth. Now, so again, a crux of the, you can say, the previous slide, that is four stages of the lung development they are shown, that is pseudoglandular, canalicular, terminal sac, and alveolar period. Now fetal breathing movements are, they starts before birth, occurs intermittently, and exerts sufficient force to cause the aspiration of amniotic fluid. Now, fetal breathing movement are essential for normal lung development. At birth, the lungs are approximately half filled with fluid. Aeration at birth rapidly replaces the intra-alveolar fluid by the air. The fluid from the lung is cleared by through mouth and nose by pressure on the thoracic wall during vaginal delivery. So, next is through pulmonary arteries, veins, and capillaries, through lymphatics. So this is the applied anatomy, hyaline membrane disease, which we have discussed in detail. Then ectopic lung lobes from esophagus or trachea. Then azygous lobe, which is given the name lobe of Risberg. Then congenital cyst of lung, sequestration of lung, absence of lungs, or hypoplasia of lung. Then more than one lobes may be that, you can say, standard division of the lobes. If it is more than that, we call it as supernumerary lobes. Ectopic lung lobes arise from the trachea or esophagus. They form additional respiratory buds of the trachea and foregut. You can see this is ectopic lung lobe. Azygous lobe is portion of the upper lobe of the right lung that lies medial to the arch of the azygous vein, seen in right lung because azygous vein itself is on the right side, lies in the floor of the vertical fissure lined by the pulmonary pleura. So this is azygous lobe. You can see this is azygous lobe. This is the X-ray picture of azygous lobe. You can see here. Congenital cysts of lung, that is terminal bronchiole dilate to form the multiple cyst producing honeycomb appearance. You can see in this the honeycomb appearance is there. So in this X-ray picture they are visible. You can see this. So honeycomb appearance is there. Sequestration of lung tissue separate from the tracheobronchial tree. So this is, you can see. So intralobular sequestration is within the lung tissue, extralobular is outside the lung. So these are this sequestration of lung can happen in two ways. It may be within the substance of the lung tissue, or it may be outside the lung. Medical legal importance of lungs is lungs of newborn infant born alive always contain some air within it, hence it floats in water and crepitate on pressure. Lungs of newborn infant born dead or stillborn are firm and sink when placed in water because they contain fluid, not air. It is firm and does not crepitate on pressure and sinks in water. So this is the medical legal importance, hence important in differentiating between stillbirth and killed live born baby. So this is all about the development of the respiratory system. Thank you very much.